All right, let's get right into it. This is a story about a founder and how she took a decade of research fueled by a deeply personal mission to tackle a massive, broken system right at the very heart of medical innovation. So, this whole thing really starts from a very personal place for the founder, Dr. Matthews Allen. Her parents, they were battling Parkinson's and multiple myeloma. And she saw, up close and personal, that clinical trials, well, they aren't just some abstract science experiment. For families like hers, they are a lifeline, literally. And that personal fire, that sense of urgency, it's what fueled an entire decade of her academic research. She started digging into this incredibly powerful and honestly super underused tool for public health. And that tool, it's crowdsourcing. What she found, time and time again in her research, was pretty incredible. When you open up a problem to an entire community, a crowd, instead of just a handful of experts in a boardroom, you don't just get a bunch of noise. No way. You actually get better solutions. You build real trust. And crucially, you finally start to really engage with groups that are so often left out of the conversation. So there was this huge gap, right? The research was crystal clear, but the industry, the world of clinical trials, was doing something completely different. And it turns out the industry has this fundamental problem, a massive, incredibly expensive problem. But it's probably not what you're thinking.
Okay, get this. 80%, a staggering 80% of all clinical trials fail to meet their recruitment deadlines. Just think about that. It creates this gigantic bottleneck, grinding the development of new medicines to a halt.
And we're not talking about small potatoes here. For every single day a trial gets delayed, it's costing the sponsors an estimated $600,000 in losses. The financial bleed is just immense. It's a huge, huge problem. But here's where it gets even worse. This failure, it's not spread out evenly. Take Black Americans, for example. They make up about 13% of the US population, but historically, they've accounted for less than 5% of all trial participants. This isn't just some interesting statistic. It's not a data gap. It is a full-blown equity crisis.
And here's why that matters so much. For a lot of patients, especially those who are uninsured or underserved, who are disproportionately Black and brown, a clinical trial is often the only way they can get access to free, specialized medical care. So when you lock them out of trials, you're literally locking them out of healthcare, period.
So, this is where the idea for curated clinical comes into the picture. It basically takes the traditional model and just flips it completely on its head. Forget the old top-down, we are the experts and we know best approach. This is built from the ground up, entirely on community partnership. The whole thing is based on one simple, but honestly pretty radical question. What if the real experts on how to reach a community are the people who are actually in that community? It seems so obvious, right? Stop guessing, start asking. So to prove this could work, they didn't go off and build some complicated, expensive app. Smart move. Instead, they built what they called a listening infrastructure. And then they ran a test, a real live test. And listen to the question they asked. It wasn't some cold clinical thing. It was deeply human. They went to Black and brown community members all across North Carolina, young people, older men, everyone in between, and they simply asked this. And what they got back? Wow. It was basically a complete ready-to-use playbook on how to talk to the community. Seriously, things like lead with trust, not a bunch of dry facts. Acknowledge the history of Tuskegee right up front before you say anything else. Frame it as an act of love. Use FaceTime, not some glossy brochure. I mean, this is the kind of real, authentic insight that no fancy marketing agency in a skyscraper could ever come up with. But the biggest lesson from that whole experiment was maybe the most important and also the most humbling. And it's this. A digital platform, yeah, it can help you reach a lot of people. It can accelerate things, but it absolutely cannot manufacture or replace the human trust, the real connection that's required for someone to actually say yes. And that one insight, it changed everything. Suddenly, the focus wasn't just on running these one-off contests anymore. It shifted to building a true community home, a place with member profiles and public voting and leaderboards, all the things that make people want to come back, to stay, to actually be part of something. I mean, this chart just lays out the whole evolution perfectly. They went from a one-time contest to a community home. The user went from being a passive target to an active contributor. And the outcome? It's not just a clever recruitment idea anymore. It's a real, durable pathway to healthcare access.
So, it leaves you with this final, really powerful thought. If this community-first model, this simple act of listening, can start to fix one of the biggest, most stubborn challenges in modern medicine, what else could it do? What other supposedly impossible problems could we finally start to solve if we just took the time to build the architecture to listen?